All right, we're going to be reviewing the anatomy of the trigeminal nerve. As we start to give injections and look at giving injections on our partner and ultimately our patients, we need to review the anatomy of where we're going, what we're going to be numbing, and what we're going to be doing. We're going to be working on anesthetizing the trigeminal nerve. The trigeminal nerve is made up of a motor and a sensory root. It is the fifth cranial nerve. The motor root part of the trigeminal is smaller, and it is not going to be an area that we are anesthetizing, but we still need to make sure we know that the motor root supplies the muscles of mastication, the masseter, the temporalis, and the medial and lateral pterygoid, not the buccinator. That is not a muscle of mastication. It does supply the mylohyoid muscle, the anterior belly of the digastric, and the tensor tympani and the tensor belli palatini. The trigeminal sensory root originates in the trigeminal ganglion and divides into the three separate roots. So our B1 is our ophthalmic division. That is coming through the superior orbital fissure. Our B2 is the maxillary division, and that is coming through the foramen rotundum. And our V3 is our mandibular division, and that is coming through the largest foramen, which is the foramen ovale. Remember, if we're looking in the inside of the skull, our superior orbital fissure, and then our ROS, our rotundum ovale spinosum, but we're not talking about spinosum in this case. Here's a picture of a skull showing the ophthalmic division heading off after the trigeminal ganglion. So our ophthalmic division going through the superior orbital fissure, our V2 division, our maxillary division, going through the foramen rotundum, and our V3 division is going to be going through the foramen ovale and going to the mandibular area. The ophthalmic division is the smallest of the three divisions. It's all sensory, exits through the superior orbital fissure, supplies the eyeball part of the nose, the forehead, eyelids, and the side of the nose. Our maxillary division, our V2 division, goes through the foramen rotundum. It supplies part of the face in the maxillary area. And if you think about this one, it is all of our maxillary injections, to include our Nasopalatine, which is in the anterior palatal area, our greater palatine, which is our palatal posterior area, our posterior superior alveolar nerve, which is the maxillary molar area, our middle superior alveolar nerve, which is our premolar mesiobuccal root of the first molar area, and then our anterior superior alveolar nerve, which is our anterior maxillary area. Our PSA, or our posterior superior alveolar nerve, our landmarks are height of the mucobuccal fold, maxillary tuberosity, and the soft depression after the maxillary tuberosity distal to the last molar. And for this injection, we are going to be getting the maxillary teeth, interproximal and buccal gingiva, except for the mesiobuccal root of the first molar. We're going to be using a short needle going about halfway into that area and anesthetizing at a 45-degree angle to the occlusal plane and a 45-degree angle to the mid-sagittal plane, because we're wanting to avoid the pterygoid plexus of veins back in that area. This is the number one area where potentially a vein could be nicked and you could create a hematoma on injection. So we want to avoid the pterygoid plexus in this area. We'll talk lots more about that as we get into the specific injections. Our middle superior alveolar nerve. This injection will numb the premolars and the mesiobuccal root of the first molar. It will numb teeth, interproximal, and buccal gingiva. Your landmarks are going to be the height of the mucobuccal fold near the apex of the second premolar. And that's going to be numbing the premolars and mesiobuccal root of the first molar. Our ASA, anterior superior alveolar nerve. This is height of the mucobuccal fold near the apex of the canine, using the canine eminence as a landmark. And you can see in this particular picture that we're going in at a little bit more of a 45-degree angle because of just the curve of the maxilla itself. We want to follow to the area near the apex of the canine. And we are going to be numbing from the midline, central incisor, lateral incisor, canine, teeth, and facial and interproximal gingiva for that ASA injection. If we were doing the whole anterior area, we would have to do 2 ASAs to numb the whole anterior area. Our nasopalatine nerve, or nasopalatine injection, we are going to be, our landmark is the incisive papilla over the incisive foramen, and it's at the fattest part of that incisive papilla. One injection is going to be numbing the whole anterior premaxilla triangle there. It's going to be just the gingiva of the anterior hard palate, just the gingiva. One injection for the whole area. Our greater palatine nerve is going to be just anterior to the greater palatine foramen. We're following our first molar down. It's usually between the first and second molar in the hard palate area where the alveolar process meets the palatal bone. And this is going to numb the gingiva and the posterior molars to the midline. So you can see just on half. So you would need to give 2 greater palatines to numb the whole hard palate, which is not something we normally do, but the anterior nasopalatine with just 1 injection. The greater palatine is just half of the palatal, posterior palatal area. The mandibular division is the largest of the 3 divisions, and it's exiting through the largest foramen, the foramen ovale. It's got the larger sensory root, which that's the one we're concerned with, and then the smaller motor root, like we talked about before, that goes to the muscles, the mastication, and the mylohyoid, and the tensor valentini, anterior belly of the digastric. But this one in particular, now when we're talking about it, we want to talk about the sensory portion that is providing sensory to the lingual nerve, to the inferior alveolar nerve, the incisive branch of the inferior alveolar nerve, the mental nerve, the buccal nerve, and the mylohyoid nerve. So our inferior alveolar nerve, some of our landmarks are the coronoid notch on the front of the coronoid process, our contralateral premolars. So our premolars on the opposite side, and you can see that the barrel of the syringe is going above the contralateral premolars in this picture. We're looking for the area, the linguala area that is right above the mandibular, covering the mandibular foramen, which is the opening for the mandibular canal. We are going to use our thumb on that coronoid notch, and we're going to be looking at half of our thumbnail as the height, the 6 to 10 millimeters above the occlusal plane that we're going to look to be parallel with for this injection. We're going to also look at the pterygomandibular raphe as an oral structure, and the pterygomandibular depression right in front of that. We're going to be feeling with a cotton-tipped applicator to make sure that we get around the internal oblique ridge. So quite a few landmarks and oral structures and bony structures that we have to know for this injection. The lingual nerve runs parallel to the inferior alveolar nerve, and it provides sensory to the lingual gingiva of the mandible, as well as the anterior 2/3 of the tongue and the floor of the mouth. We are not going in specifically to numb the lingual nerve by itself. It inadvertently gets numbed as we're doing the inferior alveolar injection. Some people will experience a shock or a zing as we give the inferior alveolar injection, and that would be the needle coming close to or possibly hitting the lingual nerve on our way by. They'll get instantly numb in their tongue, and they'll let you know that they felt something, and it's usually because we went close by that nerve. They'll get the lingual shock, not because we got the inferior alveolar, but because we went close to or went by the lingual nerve. Our buccal nerve, or our long buccal nerve, this is just going to anesthetize the buccal gingiva of the mandibular molars. If we were doing a mandibular area, scaling a mandibular area, we would want to give the IA to get all of the teeth, all of the tissues for the mandibular area to the midway, to the midpoint, the halfway midline. And then we would also need to do this long buccal injection to get the facial gingiva of those mandibular molars and the area of the cheek in the vestibule. Our landmarks would be retromolar pad, distal to that last molar, our buccal fat pad, and just below the occlusal plane. We have the incisive branch and we have the mental branch, or the mental nerve. The mental nerve and the incisive branch, the location is the same for the injection. And it is in the vestibule near that mental foramen. When you're searching for the mental foramen, you're going to feel from the molar to the canine, because it's usually between the first and second premolar, but not always. So you're going to feel and palpate that area between the molar and the canine to feel where that mental foramen is. You're going to go in the vestibule area near the mental foramen, 4 to 5 millimeters into that area, and you are going to do your injection there. If you just do the injection, it's going to numb the mental, which the mental is your just the skin of your chin, just the skin of your chin, your lip, your lower lip, and the inside cheek area. If you massage it in once the injection is given, then the anesthetic will diffuse into that mental foramen and it will numb from premolar to the midline. Premolar to the midline. There are often times in practice where I give a mental on the right side, mental on the left side, and I've got premolar to premolar numbed. There are a lot of people just in general who are sensitive in that lower anterior, and if I can give those two, I'll call them mental injections, and I told you this in class, I call them mental injections, but really they're incisive because I'm rubbing them in, and the anesthetic is diffusing into that mental foramen to anesthetize the incisive branch of the inferior alveolar nerve. So the location's the same. The difference is the massaging near the mental foramen. So the anesthetic diffuses into the mental foramen. The mylohyoid nerve, it's partly motor, provides sensory to the skin on the chin and sensory to the mandibular incisors, but it also provides some sensory to the pulp of the mandibular teeth, particularly the mesiobuccal root of the mandibular first molar. There will be times, most of the time this would be a dentist not being able to get a person numb on their mandibular first molar. A reason could be for the person not getting numb is that there is innervation from the mylohyoid nerve to that first molar. That would be a reason for the mandibular molar not getting numbed. In that case, the dentist might try to do an injection where they go into the vestibule area near that mandibular first molar to try to numb that mesiobuccal root. So right near the mesiobuccal root, they might try to numb that area. Reviewing our osteology and just the bony areas. Remember our skull. We're going to have the skull out where we can review it while we're giving injections on our partners. We can review it in class as we're learning more about these injections. Superior orbital fissure is where your V1 branch, your ophthalmic branch of your trigeminal nerve comes through. V2 comes through the foramen rotundum. That's our maxillary division, and V3 comes through our foramen ovale. That is our mandibular division. We have to know where the infraorbital foramen is. The infraorbital foramen, or the infraorbital injection, is not an injection that we're going to do in class, but there are people who do that. We would use a long needle, and we would use about half of the long needle, and we would be kind of following up height of the mucobuccal fold near the first premolar, and that would take the place of our ASA and our MSA injections. So you'd do one injection, so that's the advantage of it. You'd do one injection to take the place of the ASA and the MSA. There are 28% of the people that don't have the MSA. So we go in there and we give the MSA injection, and if they don't have the MSA, we don't know who that 28% is. At that point, you're just numbing whatever that premolar is, the second premolar there where you gave the injection at the height of the mucobuccal fold. And instead of having nerves that go to the mesiobuccal root of the first molar and the two premolars, it just numbs that second premolar. The infraorbital would take the place all the way mesiobuccal root of the first molar all the way to the midline. So remember the infraorbital foramen. Our mental foramen, our mental fossa, mental ridge of our chin, angle of the mandible, all kinds of things coming back to us from oral anatomy. Inside of the skull, you guys spent a lot of time in oral anatomy on the inside of the skull. Remember where the superior orbital fissure comes under the sphenoid bone. And then our ROS, our rotundum ovale spinosum. In this case, we're not using the spinosum for any of the V1 branches going through. We're using the rotundum for the V2, and the ovale for the V3. And think about where that PSA foramen is. It's in the soft depression at the posterior of the maxillary tuberosity, in the infratemporal temporal fossa, where that soft depression is. That's where we're looking for the PSA. For our palatal injections, we've got the incisive foramen in the anterior hard palate, which is going to be right under our incisive foramen. And if you remember your final exam in oral anatomy, you had to know that the incisive foramen was covered by the incisive papilla, and the Nasopalatine Nerve came through that area, and it numbed the anterior portion of the hard palate, canine to canine. One injection, the whole anterior premaxilla hard palate area. And then our greater palatine is kind of in between that first and second molar, near where the alveolar bone or the alveolar process meets the hard palate. And that injection is going to numb the gingiva of the hard palate to the midline, premolar and molar area. And then our mandible. We've got our angle of the mandible, we've got our mental foramen, we've got our coronoid notch, our coronoid process, our mandibular foramen, and our lingula covering that or kind of protecting that mandibular foramen, our external oblique ridge, which is going to be important for the long buccal, and our internal oblique ridge, which we're going to be trying to make sure that we get around as we're doing the inferior alveolar. We're looking at the height of our occlusal plane, 6 to 10 millimeters above that is where our injection is going to go. Contralateral premolars, so our opposite side premolars. There's the ramus of the mandible, And again, our coronoid notch, coronoid process, our condyle being the one that articulates with the glenoid fossa, our TMJ area. So don't get the condyle and the coronoid process confused. Don't get the number 18 mandibular notch versus number 5 coronoid notch confused. All right, good job.